All right, hey everyone. So this is our shoulder and arm video. I'm going over the shoulder and arm course pack chapter. And again, this resource is being brought to you by the Scrubs team with the benefit of using the course pack illustration supplement supplied by the Gross Anatomy and Embryology course. All right, and going through the mission statement for Scrubs one more time. So Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. As members of Scrubs are participating in a variety of subcommittees working to create resources for students by students. And these resources are aimed to give you a neat perspective from students that have been in the class and giving you access to resources that we wish we had been exposed to while we were in the course. So the hope is that this organization will eventually become a staple of the Brody student body, and this will exemplify our unique collaborative community. And if this is a mission that aligns with your goals, or you have a desire to help those who come behind you, or if this resource is beneficial and you want to add to the resources that will be available to future classes, we would love for you to join the team in the future. Now, quick disclaimer, these resources are made by students and not by faculty, so there is a possibility for errors. We do try to take a team approach to make sure that we do not make mistakes, but mistakes do happen. If there is a contraindication with the coursework presented within the course and any of our resources, including these videos, please go by your course documents. Additionally, Scrubs is a supplemental resource, and we do not include all the material that you will be tested on your exams, so use this to broaden your learning, but not as your primary resource for your material. Now, going into the shoulder and arm unit, we're going to need to know a little bit about osteology. Now, very rarely does your course pack talk about osteology, so when it does, that means that it is very important and testable. So, talking about osteology, we're going to go over the bones of the shoulder. You have the scapula, clavicle, and humerus. So, the scapula we've mentioned before when we were talking about muscles of the back, but going over some of the quick landmarks, we want to know the acromion. The acromion is coming off the posterior portion of the scapula, and it is going to be the continuation of the scapular spine. So the scapular spine is going to continue to give you your acromion. In the front of the scapula, you are going to have your coracoid process. So the coracoid process is coming off of the anterior portion of the scapula. In between the two and a little bit inferiorly, that is where you're going to have the glenoid cavity. The glenoid cavity is where you're going to have the shoulder joint. The humerus is articulating to give you that entire joint. And we'll cover the joints of the upper body at one of the later videos. Now, looking at the posterior aspect of the scapula, we do need to know these two fossa. You have a supraspinatus fossa and an infraspinatus fossa. These fossa are going to correspond to the muscles that we will learn shortly. Okay, one more time, here is our acromion going most laterally, off of the posterior aspect, off the continuation of the scapular spine. Now, it may be worthwhile to know the angles of the scapula, the superior angle, most superiorly, the inferior angle, and then the lateral angle of the scapula. Now, I do want to point out these two joints briefly, but again, we're going to cover the joints in a later video. But in the shoulder, you have the acromioclavicular joint, which is formed by the combination of the acromion, which is part of the scapula, and the clavicle, which is coming more anteriorly to form the AC joint. Then there is a joint between the coracoid process and the clavicle, and this is going to be formed with the coracoclavicular ligament. Okay, so AC joint here, and then you got the coracoclavicular ligament more anteriorly. And then lastly, the last bone of the shoulder we need to know is the humerus. And we'll go into a little bit more of the details of the landmarks of the humerus in our next slide. So going over the osteology of the humerus, first I want to define brachium, which is the term your course pack is going to be using. The brachium is defining the upper extremity between the shoulder and the elbow. So the brachium is between the shoulder and the elbow. And the one bone that is present in the brachium is going to be the humerus. So we're going to go over some of those structures and those landmarks. The first thing you need to know is that there is a head of the humerus. The head of the humerus is articulating in that glenoid that we saw earlier that is forming that shoulder joint. Now, two major landmarks on the humerus are the greater tubercle and lesser tubercle. When you see the word tubercle, it's referring to a large bump on the bone. So more laterally, we have the greater tubercle, and more medially, we have the lesser tubercle. It's important to know your medial and lateral orientation because on the lab exams, you could be given a humerus and being asked to identify a specific bony landmark. Now, in between the two, we are going to have the intertubercular sulcus. So between the two tubercles, we're going to have an intertubercular sulcus. Okay. Now, I do want to point out the surgical neck, which is located underneath the head of the humerus. So think on a human body, there is a neck beneath your head. So that's how I remember that there's a surgical neck here. We'll come back to the surgical neck, but there is a specific correlation between fractures at this location and artery and nerve damage. That is likewise similar for the shaft of the humerus. So the shaft of the humerus is located in the medial aspect of the humerus. And then lastly, I want to point out on the lateral aspect of the distal part of the humerus, you are going to have a lateral epicondyle located right here. And then you are going to have the capitulum. The capitulum is, again, on the lateral aspect of the humerus. Now, on the medial aspect of the humerus, distally, closer to the hand, you are going to have the medial epicondyle, okay, coming medially, and the trochlea. So these are aspects of the humerus distally, right, on the distal portion of the humerus. Now, this medial epicondyle is going to come back later, again, when we talk about nerves and arteries, but the epicondyles are really important landmarks for muscle attachment as well as innervation and arterial supply. So they are very, very important landmarks to recognize and be ready for those to be tested heavily on the assessment. Now, getting into the muscles of the shoulder, we're going to be talking about a lot of muscles in this video, so I want to give you a brief rundown on the layout for most of these slides. You're going to have the muscle labeled in black. We have the origin, so O is origin, the insertion, and then we're going to give you the nerve supply and the action of the muscles. This will be the same for all the muscles that we'll cover from here on out throughout the video. So just going through that one more time, you're going to have the muscle name, the origin, insertion, nerve supply, and the action of the muscle. And you'll see that in the majority of the slides from here on out. So talking about the muscles of the shoulder, we're first going to talk about the muscles that connect the vertebral column and the upper limb. Okay, so these are not the intrinsic muscles of the shoulder, but they do have actions at the shoulder joint. So first we're going to talk about the trapezius. So the trapezius is located right here on this image. So the origins of the trapezius are the superior nuchal line, the external occipital protuberance, the nuchal ligament, and the spinous processes. So these are all midline structures for the origin. Now the insertion is going to be on the lateral third of the clavicle, the acromion, and the scapular spine. Okay, and the innervation for the trapezius is going to be cranial nerve 11, which is your spinal accessory nerve. This is a good one to know. Spinal accessory nerve innervates the trapezius muscle. Now, depending on which muscle fibers are contracting for the trapezius muscle, as you can see, that there are going to be some superior fibers, some inferior fibers, and some transverse fibers here. These are going to have different actions based on the fibers that are contracting. But primarily, you can have elevation, retraction, and upper rotation of the scapula depending on which fibers are being contracted. So that's elevation, retraction, and upper rotation of the scapula. Going on to the latissimus dorsi. So the latissimus dorsi is located here on our image. And the origin of the latissimus dorsi is going to be your thoracocolumbar fascia and the iliac crest. Okay, now for the insertion of the latissimus dorsi, it is going to wrap around anteriorly and it's going to insert into the floor of the intertubercular sulcus, which again, remember that was between the greater tubercle and lesser tubercle of the humerus. Now for innervation, one that's really important to know, the thoracodorsal nerve, this is C6 and C8. So again, when we're talking about these nerves, I'm just going to give you the nerve and the spinal segments, but I highly recommend, if you have not done so already, go back and watch the brachial plexus video, as it'll go much more in depth into how these nerves are formed, how the plexus is formed, and I feel that that is a much better way to learn these nerve and muscle pairings, as opposed to learning it just based off of rote memorization, as this video will present. Getting back to latissimus dorsi, talking about the action of latissimus dorsi is to extend, adduct, and medially rotate the arm. Notice we're talking about the arm here. So this is happening at the shoulder joint. Next we have the levator scapulae. The levator scapulae is going to originate from the cervical transverse processes. So the transverse processes of the cervical vertebrae. And you're going to insert into the superior medial border of the scapula. Now imagine that you are contracting this muscle. So from origin to insertion gets closer to origin. That is going to elevate the scapula, which makes sense. Now, talking about the nerve supply for the levator scapulae is going to be the dorsal scapular nerve. That is spinal nerve C5. And again, go back to the brachial plexus video for more information there. Now, Lastly, the rhomboid majors and minor. The rhomboid major and minor are located right here in this image. Notice that the minor is located superiorly to the major. That is important for identification purposes in lab. Now, the origin of the rhomboid major and minor, you're going to have the nuchal ligament for the rhomboid minor and the spinous processes for the rhomboid major. The insertion of both of these muscles is going to be on the medial border of the scapula. And these are both innervated by the dorsal scapular nerve. So, regionally distribution, levator scapulae, rhomboid minor, and rhomboid major are all innervated by the dorsal scapular nerve, which has spinal segment C5. Now, the action of the rhomboid muscles is going to be to retract, so pull the scapula closer to the midline, and downwardly rotate the scapula. So retraction and downward rotation of the scapula are the functions of the rhomboid major and minor. Now, getting into some more muscles of the shoulder, we are going to specifically talk about the rotator cuff muscles. Okay, so the rotator cuff muscles are the supraspinatus, infraspinatus, subscapularis, and teres minor. Now, going into these one at a time, the supraspinatus is going to originate from the supraspinous fossa, which we saw in the osteology slide earlier in this video. The supraspinatus is going to insert onto the greater tubercle. Now, remember that greater tubercle is located, it's the more lateral of the two tubercles. The innervation for the supraspinatus muscle is the suprascapular nerve, spinal segment C5 and C6. The action of the supraspinatus muscle is initiation of abduction. Just initiation, so the first 15 degrees. You will often get questions on exams that deal with supraspinatus injuries, and it's the initiation of abduction that is damaged as opposed to abduction as a whole, because we are going to have the deltoid muscle, which is going to be the primary abductor of the shoulder. But again, initiation, that first 15 degrees, if there's weakness there, think supraspinatus. The infraspinatus muscle is going to originate from the infraspinatus fossa, so below the spinous process of the scapula, so infraspinatus is located here. It is going to insert once again into the greater tubercle. Now, because this is coming below the spinous process as opposed to above, it is now going to have a different function, and it is going to laterally rotate the arm. So think about this muscle fiber contracting, bringing the insertion closer to the origin, and you will get lateral rotation of the arm. Once again, this nerve is innervated by the suprascapular nerve C5 and 6. Going to the anterior surface of the scapula, you are going to have a subscapularis muscle. The subscapularis muscle is originating from the subscapular fossa and inserting into the lesser tubercle. Remember that lesser tubercle is the more medial of the two tubercles. It is innervated by the upper and lower subscapular nerves, which have spinal segment C5 and C6 associated. The action of the subscapularis muscle is going to be medial rotation of the arm. So think about this muscle originating from the subscapular fossa, inserting onto the lesser tubercle. If I was to bring the insertion closer to the origin, what would happen to the arm? You would get medial rotation. Now, lastly, the last rotator cuff muscle is going to be the teres minor. Now, the teres minor is located right here. It is going to originate from the lateral border of the scapula, and it is going to insert into the greater tubercle. It is going to have a similar function to the infraspinatus, as they're located right beside one another, and it is going to laterally rotate the arm. Now, while it has a similar function to the infraspinatus, it does have a different nerve supply. The nerve supply for the teres minor is going to be the axillary nerve, C5 and C6. So teres minor, innervated by the axillary nerve, spinal segment C5 and C6. Now, I do want to point out briefly, look at all of these spinal segments. Even though these muscles are supplied by different nerves, the spinal segments are the same. C5 through C6 is going to innervate all of the muscles of the rotator cuff. Now, going into two more additional muscles of the shoulder that aren't technically part of the rotator cuff but are part of the shoulder, we are going to talk about the deltoid and the teres major. So the deltoid is located here. It is the most lateral muscle of these muscle groups, and the teres major is located right beneath the teres minor muscle, which we saw previously. So starting with the deltoid is going to originate from the lateral third of the clavicle, part of the acromion, and scapular spine. So we're seeing the portion of the scapular spine here. It is inserting into the deltoid tuberosity. This is a region on the humerus. So it's inserting onto a region of the humerus called the deltoid tuberosity, and that deltoid tuberosity is one of the most lateral portions of the humerus. So with that in mind, if our origin is more medially and our insertion is more laterally, the main action of the deltoid muscle is going to be abduction of the arm. Now, it does have anterior and posterior fibers that can contract independently, that can give you slightly different functionality. So the anterior components can also flex and medially rotate the arm, whereas the posterior components are going to extend and laterally rotate the arm. And just like the teres minor, so teres minor right beneath it, deltoid right above it, those muscles are side by side. This muscle is innervated by the axillary nerve, spinal segment C5 and C6. Now the teres major, while it is directly beside the teres minor, does have a different nerve supply. The nerve supply for the teres major is the lower subscapular nerve, C5 and 6. Remember that this lower subscapular nerve was also supplying the subscapularis muscle. The origin for the teres major is going to be the inferior angle of the scapula, which we can see here. There goes your inferior angle of the scapula, and here goes the origin of the teres major. The teres major is then going to insert into the medial lip of the intertubercular groove. Now remember, the intertubercular groove is the groove between the greater and lesser tubercle of the humerus, which is located anteriorly. So that means that this muscle has to wrap around anteriorly to insert into the intertubercular groove. And we'll see that on a future slide in a little bit more detail. Because of the origin and insertion of this muscle, it is going to adduct and medially rotate the arm. That medial rotation portion is due to the insertion on the anterior aspect of the humerus in the intertubercular groove. Now, going through some of the neurovasculature that you need to know for this region and some of the spaces that are associated. So there are three spaces that you need to know when it comes to the posterior region of the shoulder. The first is the quadrangular space, which is bordered by the teres major, teres minor, long head of the triceps, and the humerus. So I'm going to show those borders now. So the quadrangular space, which is located right here, is bordered by the teres minor, inferiorly by the teres major, medially by the long head of the triceps, and then laterally by the humerus. And that is going to form this space right here. Now in the quadrangular space, you are going to have the axillary nerve and posterior circumflex humeral artery exiting. These spaces are extremely, extremely important when it comes to identification of neurovasculature in the lab. In the lab, you will be given an arrow that will point to a nerve, and it will ask you to identify said nerve or said artery. The only way that you can do so in this space confidently is to look at what associated space does it come out of. So if I saw this nerve here, and I recognize that this is the quadrangular space because I have a superior border of the teres minor, inferior border of the teres major, I have the long head of the triceps and the humerus forming the medial and lateral borders, I can then be confident to say that this is the axillary nerve. Now, two other spaces that we need to know is the triangular space and the triangular interval. The triangular space is located medially. So here's a triangular space here. The triangular space is bordered by the teres major inferiorly, the teres minor superiorly, and the long head of the triceps. So I know this says lateral head here. This should say long head of the triceps coming right through there. And that is going to give you your triangular space. Okay, and the vessel that passes through the triangular space you need to know is the circumflex scapular artery. So circumflex scapular artery passing through the triangular space. Lastly, we have our triangular interval. Our triangular interval is bordered by the long head of the triceps, the lateral head of the triceps, and then our teres major muscle superiorly. In the triangular interval, we are going to have the radial nerve and deep brachial artery. So if you see the borders, if the borders are the teres major superiorly, long head of the triceps medially, and then lateral head of the triceps laterally, that will tell you you're in the triangular interval, and the nerve that you are seeing here is the radial nerve, and the artery you're seeing is the deep brachial artery. So once again, really, really nail down these spaces and their associated neurovasculature because these are guaranteed to come up on not just the computer exam, but on the lab exam as well. Now moving on to the arm, so we're moving out of the shoulder. we are going to talk about the anterior compartment and the posterior compartment. Your anterior compartment is going to consist primarily of the flexors. So there are three muscles here that we need to know. The first is the biceps brachii. So the biceps brachii is going to have two heads, a long head and a short head. The origin of the long head is going to be the supraglenoid tubercle of the scapula, which is located relatively close to where this arrow is pointing now. What I want to point out is that the tendon here is passing in between the two tubercles that we mentioned previously. The short head of the biceps brachii is originating from the coracoid process of the scapula. Okay, so it's the short head. So if you're looking at the two heads of the bicep, the short head is more medial than the long head, which is more laterally. So the L, I think, for the biceps brachii helps me identify that the long head is lateral. Now, the insertion of both of these is going to be a common tendon that is going to insert onto the radiotuberosity. Okay, so the insertion is the radiotuberosity. When we talk about nerve supply, the nerve supply for all of the muscles in the anterior compartment of the arm is going to be the musculocutaneous nerve. The musculocutaneous nerve has spinal segment C5 through C7, and that will be true for all the muscles in the anterior compartment of the arm. Primary functions of the biceps brachii are to flex the elbow as well as supinate the elbow when you are flexed. So flexion of the elbow and supination of the elbow when the elbow is flexed. Next, I want to mention the coracobrachialis muscle. The coracobrachialis muscle is going to go from the two sections that are said in the name, the coracoid process and the brachium. So the coracoid process and the humerus. So with that in mind, our origin is from the coracoid process. Here is the muscle belly here, and we are inserting into the humerus. So this muscle does not cross the elbow joint, so it does not have any functionality at the elbow. Instead, the action of this muscle is going to be to flex and adduct the arm. So flexion and adduction of the arm, not having any action at the elbow joint. One more time, that was the coracobrachialis. Finally, we have the brachialis muscle. The brachialis muscle is going to originate from the humerus, meaning that it originates below the shoulder joint, so it has no action at the shoulder, and it is going to insert into the coronoid process of the ulna. So the coronoid process of the ulna. And here goes our brachialis muscle. It is deep to the biceps brachii, and it is inserting into the coronoid process of the ulna. Once again, this muscle is innervated by the musculocutaneous nerve, spinal segment C5 through C7, as the rest of the muscles in this compartment of the arm. And this muscle, the brachialis muscle, is the primary flexor of the elbow, not the biceps brachii. So the brachialis is the primary flexor at the elbow. Now, I want to point out this particular image is this something really high correlation that you will see in lab. The musculocutaneous nerve is going to pierce the coracobrachialis muscle. I use the musculocutaneous nerve and coracobrachialis in conjunction to identify these two structures in lab. So what I want to point out here is we're looking at the brachial plexus. The brachial plexus, this anterior division, is going to make that M shape. So it goes there. Here is your M. That is going to be musculocutaneous, median, and then ulnar nerves. But if you're not very confident in your identification of the M, so you're not entirely sure that this is the musculocutaneous nerve, look at this muscle belly right here. This muscle belly right here is located very medially. It's going to originate from the coracoid process, and this nerve is going to punch directly through this muscle belly. So if you see a nerve punching through this muscle belly, which is the coracobrachialis, then you know that this is the musculocutaneous nerve. Vice versa, if I'm trying to identify the short head of the bicep, which I'm highlighting now, versus the muscle right beneath it, the coracobrachialis, I can look to see does this muscle belly have the musculocutaneous nerve punching through it. If the answer is yes, then that is going to tell me that is indeed the coracobrachialis muscle. So one more time, I just want to point this out. Musculocutaneous nerve punching through the coracobrachialis. This is a very high yield association to make when you're in lab. Now, moving on into the muscles of the arm in the posterior compartment. So ignore this up here. We are talking about the posterior compartment now. You are going to have the triceps brachii and the anconeus. So the triceps brachii is going to have three heads, a long head, a lateral head, and a medial head. The long head is originating from the infraglenoid tubercle of the scapula. So that is this portion here. Here is your long head. originating from the infraglenoid tubercle of the scapula. The lateral head and medial head are both originating from different portions of the humerus. The insertion of all of these is on a common tendon that is going to insert onto the olecranon process. Okay, so insertion onto the olecranon process. This muscle is innervated by the radial nerve, which has spinal segment C5 through T1 associated, and it is the primary extensor of the elbow. Now the long head, because it's originating from a more medial portion than the lateral head and medial head, can also extend and adduct the arm. So the long head can also extend and adduct the arm. Triceps brachii, however, is going to have a primary function of extension of the elbow. Now, one other muscle of the posterior region of the arm is going to be the anconeus. So the anconeus is located right here. The anconeus is originating from the humerus, and it is inserting into the ulna, innervated by the radial nerve, as it is part of the posterior compartment of the arm. The action of the anconeus is to assist the tricep in extension of the elbow. So it is not very strong and is going to weakly assist the tricep in extension of the elbow, but this is a muscle that they do like to tag in labs, so it's worth knowing. The anconeus is going to be on the lateral posterior aspect of the arm. Going over really briefly some cutaneous innervation of the arm. This is something that I think if you go back into the brachial plexus video, is pieced out a little bit in more detail, but I want to point out that the lateral aspect, so this is lateral over here, the lateral aspect of the shoulder is innervated by the superior lateral cutaneous nerve of the arm. This superior lateral cutaneous nerve of the arm is a continuation of the axillary nerve. So one of the ways that you can assess for axillary nerve damage is by seeing if a patient has lost sensation to this lateral portion of the shoulder. Now we also have the inferior lateral cutaneous nerve of the arm and then the posterior cutaneous nerve of the arm. Both of these nerves are going to be continuations or branches of the radial nerve. Okay, and then we have a nerve that is supplying the medial aspect of the anterior portion of the arm, and that is going to be the medial cutaneous nerve of the arm. Okay, and then one more time, here's the same thing looking from a posterior view. Now, I want to talk about some nerves and vessels. We're going to talk about this a little bit more when we talk about specific clinical correlations, but this is a relatively high-yield topic. So I want to point out that here we're seeing that anterior division one more time of the brachial plexus, making its M. So there goes the M there, with the most superior portion being that musculocutaneous nerve, then your median nerve, and then your ulnar nerve. Now, if we follow these nerves down, what I want to point out is that the ulnar nerve here is passing posteriorly to the medial epicondyle. It is not passing into the forearm anteriorly. It passes behind the medial epicondyle, so we can't even see it. And then it's going to enter the forearm distally. The median nerve, however, is going to pass anteriorly into the forearm, whereas the radial nerve is behind the humerus, coming laterally, and then it will eventually pass into the forearm on the lateral aspect. Now, one last thing I will point out is this musculocutaneous nerve is supplying all the muscles of the anterior compartment of the arm, but as it leaves the arm into the forearm, it is going to become the lateral cutaneous nerve of the forearm. So it is now doing cutaneous innervation as opposed to muscular innervation, as it did in the arm. So as a brief overview of the nerves that are important as we're in relation to the arm. What might be even more important is the vascular supply of the arm. And I say this in the sense that the vascular supply is heavily tested on the lab practicals. There are also highly common correlations that are made between fractures and vascular damage. So as we come through the brachial artery, it's passing anterior to the humerus. It is giving off a branch posteriorly that is the profunda brachia artery. So profunda means deep, so the deep brachial artery is passing posteriorly. The brachial artery, which is anterior, is going to be passing down the humerus, and it is going to give off on the medial side a superior and inferior ulnar collateral artery. So the way I like to think about this is a collateral artery is running from superior to inferior. So you get a superior and inferior collateral artery that will then anastomose with a recurrent artery. A recurrent artery is running from inferior and coming back up. So superior and inferior ulnar collateral arteries that pass anterior and posterior to the medial epicondyle. And then you have a superior and inferior ulnar recurrent artery. Here they're labeled anterior and posterior. And those are going to anastomose together to supply the structures around the medial epicondyle. We have something similar on the lateral epicondyle. We're going to have a radial collateral branch and a recurrent radial artery. So these two are analogous to the same on the medial side. However, instead of having two, you're just going to have one. So the radial collateral branch and then the recurrent radial artery. And again, medially have a superior ulnar collateral artery, inferior ulnar collateral artery, and those are going to anastomose with the ulnar recurrent arteries, the anterior and posterior. As we come distally, the brachial artery passes into the forearm. It is then going to bifurcate into a more laterally oriented radial artery and a medial portion that is going to be your ulnar artery. And these are going to be the focus of another video in the future. Now, last thing before we get into the clinical correlations for this video, we are going to talk about the cubital fossa. The cubital fossa is bordered by the superior border of the cubital fossa is the medial epicondyles. So the medial epicondyle to lateral epicondyle, you imagine an imaginary line, that is going to be the superior border of the cubital fossa. The medial border of the cubital fossa is your pronator teres, whereas the lateral border is going to be the brachioradialis muscle. These are all muscles that we will learn in another video. But that space right in between is going to be the cubital fossa. Now, it is worth knowing that the floor of the cubital fossa, so everything that you can actually touch if you put your finger through here, would be the brachialis muscle and the supinator. Again, muscles that we will go more in detail into at a later date. Now, with the cubital fossa, what's important to note is that from medial to lateral, there are a couple of very important structures that pass within the cubital fossa. So starting on the medial aspect, we are going to have the median nerve. Now, I want to point out, it is very, very important. In the forearm, the ulnar nerve is going to be the most medial nerve that you will see. However, at the cubital fossa, you do not have the ulnar nerve in the arm. In the anterior compartment of the forearm. That is because the ulnar nerve passed behind the medial epicondyle. It will enter the arm somewhere a little bit distally. So, at the cubital fossa, the most medial nerve that you will see is the median nerve. Okay, so you have the median nerve, followed by the biceps brachii, the brachial artery, then followed by the tendon of the biceps brachii, and lastly, you will have the radial nerve. So, going from medial to lateral in the cubital fossa, 4 structures you need to know. Most medially is the median nerve, followed by an artery, the brachial artery, followed by a muscle tendon, which is the tendon of the biceps brachii, and then followed by the radial nerve most laterally. Again, the ulnar nerve is not present in the cubital fossa as it is wrapped posteriorly to the medial epicondyle. Now, going over some clinical anatomy briefly, this clinical anatomy comes up all the time. If not in this course, then in your preparations for step 1 and probably future exams. But the clinical anatomy that I want to talk about here is where you can have fractures of your humerus and the associated nerve and arteries that can be damaged. So the first fracture we're going to talk about is a fracture at the cervical neck. So a fracture at the cervical neck can potentially damage the axillary nerve and the posterior circumflex humeral artery. Remember that the axillary nerve and posterior circumflex humeral artery were both running through the same space in the posterior region of the shoulder, so it makes sense that these could both be damaged together with damage at the cervical neck. The next one we want to talk about is a midshaft fracture. So this is a fracture in the middle of the humerus. This is going to potentially damage the radial nerve and profunda brachia artery. So these are in the posterior compartment of the arm. Next, I want to talk about a fracture of the medial epicondyle. Remember, we have pointed this out many times in this video. The ulnar nerve is passing posterior to the medial epicondyle. Because it passes posterior to the medial epicondyle, damage to the medial epicondyle can damage the ulnar nerve or one of the ulnar collateral arteries that is supplying this region. And lastly, one that comes up probably most commonly on national assessments is the supracondylar fracture. A supracondylar fracture is a fracture above the medial and lateral epicondyles that goes across the humerus, and this can potentially damage the nerve and artery that are directly anterior to it, which is going to be your brachial artery and the median nerve. So, really important, take a minute to go through these clinical anatomy fractures because these are going to be high yield when it comes to assessment purposes. And that will take us to the end of this video.